So welcome everyone, and thank you so much for joining us today. My name is Romana Primus, and I'm honored to be moderating today's webinar, Finding a Path to the Post-COVID World. In my professional life, I was a clinical immunologist and allergist, and I have been intimately involved with the University of Haifa for decades. I have the pleasure of serving on the board of the American Society for the University of Haifa. But just over 6 months ago, much of the world was in the throes of a second wave of COVID-19. We were facing an exponential rise in cases and in mortality. The first vaccination was still months away from being administered, and we could only speculate on what a return to normalcy might look like. Today, more than 1.5 billion doses of vaccine have been administered worldwide, albeit mostly in higher income countries. In many places, borders are reopening and restrictions are easing. In partnership with the Canadian Friends of Haifa University, we have reconvened our panel of esteemed experts representing Israel, the EU, and North America. We are going to consider both the global successes and the remaining challenges. Before we begin, I would like to just take a moment to acknowledge the harrowing events in Israel. We offer our support and our empathy to each and every person impacted and hope for peace, coexistence, and understanding. With that, I would like to briefly introduce our panel. Dr. Manfred Green is the director of the International Masters in Public Health program at the University of Haifa. He is the past head of the public health branch for the IDF and a founding director of the Israel Center for Disease Control. Dr. Andrew Morris is a professor of medicine at the University of Toronto and medical director of the Sinai Health System University Health Network Antimicrobial Stewardship Program. Dr. Dorit Nitzan is the Regional Emergencies Director for the European region of the World Health Organization. She came to WHO from the Israeli Ministry of Health and was also active in Physicians for Human Rights, a humanitarian NGO. As a reminder to the audience, please submit your questions through the Q&A icon at the bottom of your Zoom screen at any point, and we will do our best to address them. Dr. Nitzan, a recent WHO report on the pandemic showed that the Americas accounted for 40% of all the COVID-19 deaths last week, while India alone accounted for 30%. How much of a concern are the spiraling numbers in these areas?
Yes, thank you. Thank you very much, Dr. Primus. We are really concerned. We are concerned because the numbers, the numbers of death in the world actually are following the disease rates by usually 2 to 3 weeks. So the numbers in India will unfortunately increase. Every person that loses their life for this virus is really, it's a huge loss. And the numbers that we hear today, they are beyond our understanding. We cannot capture the magnitude. We cannot understand what's going on. And we see that the regions, countries where people do not have access to vaccines, live in crowded settings and cannot really maintaining the public health and social measures, these areas are at high risk. And we are asking the world to help us and to help them so that we can overcome this virus. It's very hard, very worrisome. But from the other hand, Dr. Primus, we see the good news from countries that do succeed to vaccinate. We see that in Israel, the numbers are so low now, the incident, the death, and these are great news. Also, we see the same in other countries where the vaccination coverage has been increasing. And so that type of what's going on in the world, this unbalanced humanitarian or human's life is putting us all at risk, because the variants are happening at all the time, and they are putting us at risk. So yeah, we are concerned.
Thank you. Dr. Morris, with over 1 million confirmed cases and just over 3% of its population fully inoculated against COVID-19, Canada has come under increased scrutiny for its handling of the virus. Why are the vaccination levels so low in the country, especially with Canada's health system that has been held up so often as a model? And what is Canada doing to change this?
Yeah, so fortunately, Canada over the past number of weeks has emerged as one of the world leaders in terms of vaccination. It all depends on how you measure penetrance of vaccination. So Canada, like the United Kingdom, have taken the approach that it's better to get as many people with one needle in the arm as possible, and then delay the second dose so that we can get more people vaccinated. In fact, over the past 2 weeks, there is no country on the planet that is vaccinating as quickly per capita as Canada is right now. And we're just about to overtake the US. Probably by early next week, we will have more people with a single vaccine in arms than the US. And there's a lot of talk in Canada of wanting to be number one. So that would be, hope to even exceed Israel's ability. It's not without controversy. There's certainly been a large amount of controversy around the strategy of delaying the dose in terms of protecting, in particular, older adults who it's definitely at least exposed some risk. And we've definitely had older adults be admitted to hospital, some even critically ill after receiving only one dose. But what it has meant is an acceleration of our recovery. We had a brutal third wave throughout much of Canada. Two of the larger provinces, but certainly not the largest provinces, Alberta and Manitoba, are currently right in the midst of brutal third waves, to the point where they're even having to ship intensive care unit patients several hundred kilometers away to beds in neighboring provinces because of the shortage or the low capacity and how large it's hit. Canada did suffer from having delayed access, but in many ways we are a very privileged country. We ordered way more vaccine than we need. And at the moment, for a country of 37 million, we're getting somewhere between 2 and 2.5 million doses of vaccine a week being delivered to us. So we should have most adults, and in fact, most people over the age of 12, get their first shot of vaccine by July 1st, which is Canada's birthday. So in general, I'd say we're actually doing quite well.
Well, that sounds excellent. Well, thank you for the update. Dr. Green, Israel is around 60% fully vaccinated and continues to see low levels of new cases. How much can we read into this successful vaccine impact in Israel as a way out globally of the pandemic?
I think, thank you very much, Dr. Primus. I think the first thing is obvious to most of us, maybe to all of us, that the vaccine is very effective, probably more effective than we expected it to be. Certainly the mRNA vaccines are particularly effective. And so we've succeeded in vaccinating a very high percentage of the eligible population, which means above the age of 16, we're still not vaccinating children. We reached a stage where not only about 60% are vaccinated, but you have to add to that probably anything around 10% who've been infected or whatever. So we're not far away from the estimates that were made for what we would call some kind of herd immunity. And we've certainly seen the disease rates drop very rapidly to the extent now that from thousands of cases a day, I think in the last few days, we've had maybe 10 or 15 cases a day, and sometimes even less. So basically, I think we're at a level now where we have what we might call some kind of herd immunity, but we have to be very cautious because there are still pockets of the population who are not immunized. And that means we have the possibility of outbreaks in those pockets of people, particularly when we open the borders, because the borders are pretty closed at the moment. So that's another issue. And we need to make sure that the Palestinians get vaccinated because they are our closest neighbors. And then finally, and this has been mentioned by Dr. Nitzan and others, is that the variants are a concern. So we're doing well against the current variants, the current viruses that are circulating. We need to be very careful about what might happen if there's a significant change in the virus.
So how is the battle between Israel and the Palestinians impacting the vaccination? Are the centers still able to continue to vaccinate?
Well, it's clearly, the whole situation is a tragedy in itself. So, you reach a stage now where COVID-19 has become almost, in some senses, a secondary issue because there's such a major conflict at the moment. But certainly that's interfering. And in Gaza, we have very little communication now. We really don't know what's happening. We know there's been a lot of disease there. The way in which vaccines will get into Gaza now is going to be very challenging, and I'm sure WHO will be very active there. But I would say I'd put out another call to the Israeli government. I think it would be not only good for the whole population to make sure the Palestinians are vaccinated, but I think it's a good time to even show a goodwill gesture and actually make sure that the Palestinians receive vaccines. I think we should be helping them.
Yeah, well, thank you. I certainly agree with that. Dr. Nitzan, there are these huge disparities in the availability of the vaccines around the world. Now, as you know, COVAX is a vaccine sharing plan, which the WHO has been leading, and it aims to vaccinate 20% of the population in the 92 low and middle income member states before the end of the year. Could you please tell us more about COVAX and how it plans to achieve its objective?
Thank you. COVAX is a platform, a solidarity platform that was established by UNICEF, Gavi, CEPI, and WHO. Each of the organization brings into that platform our expertise. So one does more of the procurement side. The other one is very good in health promotion, communication, and children health. The other one is very good in technical knowledge of the virus, etc. So we are all together, where the idea is that money that countries and donors provide to the world are coming into that bank, kind of, and that the procurement would go first to those that cannot fund their own procurement. And as you rightly said, we are planning to actually vaccinate 20% of the world's low and middle income countries using the COVAX platform. Countries have obliged the money, the amount of the vaccines. And I must say that we have mobilized, never seen anything like that in such a speed that many countries did receive some vaccines, but really not enough. What we are very glad and grateful to hear is that countries in the EU, Germany and others, as well as the United States and other countries, have really given more than their share into the COVAX. So we are optimistic. We are asking more countries and more donors to put more funds into it. Of course, from the other hand, getting the costs, to lower the costs of the vaccines is very important. We heard President Biden, we heard his call to the industry to lower the price by the different mechanisms. We know that other countries are not so keen to support it, but we still very much ask, please, let's think of humanity. We are all one. We cannot leave anyone behind because, as Professor Green said and Professor Morris, if we don't cover everyone, at the end, the variants will threaten all of us. So our global security depends on such a wonderful, unique, and very useful platform.
Well, thank you, Dr. Nitzan. Dr. Morris, you mentioned that in Canada, a huge percent of the population aged 12 and up would be vaccinated soon. So I have a question about the youth vaccinations. Do you think that it's more important on a worldwide scale to vaccinate the young people, the people aged 12 to 16, as opposed to using those vaccines worldwide to help stem the pandemic?
I wish I knew the exact answer to that. Thank you for an interesting and challenging question. As you know better than I do, Israel's numbers, which have not largely involved child vaccinations, certainly 12 to 16 or 12 to 15, have been quite remarkable and probably go against what many people initially thought, which was that you would need to vaccinate children as part of an important herd immunity strategy, meaning that the more people that you get vaccinated, especially in households and in schools, it would protect the adults as well, and it would prevent ongoing transmission. Really, the more people that get the vaccine, the better. And mathematically, most of us anticipated that magic number of how many people would need to be vaccinated to protect us and prevent further waves was going to be somewhere between 75 to 85% of the population. In Canada, the percentage of the population that are children and youths is less than it is in Israel, which in fact argues against the huge need in Canada to vaccinate young people, because they do make up a larger percentage of the population in Israel, and yet you've still been successful. I think what the real challenge that I think many countries face right now is it's more of a political than a scientific one. So the Canadian government has plenty of vaccine right now, or anticipate getting plenty of vaccine. We'll definitely want to vaccinate older adults or those who are at risk of getting severe disease with 2 doses. That's aside from the Johnson & Johnson vaccine, should it become used widely in Canada, which is only a 1-dose vaccine. But I think in the interest of saving the most lives, which as Dr. Nitzan just recently mentioned, globally saving lives is really important. It's unclear to me if the best use of our sundry or surplus vaccines is keeping them home here in Canada for the lower risks. and perhaps in some way ensuring that other countries get it. It's a careful dance. It's a fine dance, because I think what some people ignore is, even though children may not be at risk, children have in their sphere of community, in their households and other people who they interact with, people who may be more vulnerable. And that includes people with coexisting illness or older adults who may not be as well protected even with 2 doses of vaccine. And so immunizing children will prove protective. Whether we need all of that, I don't think we really know. And I think what we'll probably see in the US and Canada and the UK and elsewhere are national approaches that will optimize vaccination and saving lives, while at the same time working to ensure that less fortunate countries get as much vaccine as possible and as soon as possible.
And in distributing to other countries, I think it's also important which vaccine, right? Because they're much less likely to be able to use the Pfizer vaccine, which requires the special storage in remote locations, as opposed to the 1-dose Johnson & Johnson, or even the other mRNA vaccines. So.
Yeah, I think as you may know, the European Medications Agency, and then yesterday Health Canada, from the guidance of Pfizer, have said that the vaccine, at least the Pfizer vaccine, can stay at normal refrigeration temperatures for quite a while, and because of that, it's going to dramatically alter our ability to distribute the mRNA vaccines, especially the Pfizer one. And I anticipate that Moderna will follow suit soon enough. I don't know if they've studied it as carefully as Pfizer has, but this concept that we need to have it, at -70 for a prolonged period of time, and we're going to really need these intense low temperature refrigeration hubs. I think that's going away fairly rapidly, and I think that gives us a lot more promise in being able to disseminate.
Excellent. That's excellent news. I did not know that. Thank you. Dr. Nitzan, I'd like to talk for a second about variants of concern. So according to WHO, a variant is designated as of concern if it has been shown to be more contagious, more deadly, or more resistant to current vaccines and treatment. How many variants is the WHO currently following, and of how much concern are these variants at the moment?
Yes, we are following many variants and many mutations. In the regional office here in the European region, where we cover 53 member states, we meet every week, and we are in touch every day with all countries in the region, improved their sequencing capacities so that their laboratories will be able to assess the magnitude. And we do have many variants that we follow. Variants become variants of interest, usually before they become a variant of concern. They become variants of interest when we see that they are spreading, that they are suspected, and we really need to focus on them. And we have many of those, and every day the numbers are changing, because some that are of interest would become less of interest with time, and some are more of interest. Currently, we have 4 variants of concern. And those variants are the variants that, as you said, are either more transmissible or create or make the disease more deadly, tougher, etc. So we are looking at all this, and also the breakthrough, the immunization, the vaccination breakthrough. If those who were sick and can get sick again, those that were vaccinated, is there a breakthrough through this vaccination, etc. So we are looking with the best researchers in the world. So for that, we are not alone. We have our advisory group that meets very frequently. We have lots of academic institutions and laboratories around the world are working with us and support us. And together we decide, as well as with the US CDC, the ECDC, the African CDC, so Chinese, I mean, we have in different parts of the world, our partners help us to find the answers. And we have to really catch the new ones before they spread.
Thank you. So, Dr. Green, some difficult questions. At least I think they're difficult. What do we know? What have we learned about the lifespan of a vaccine? Have we started to see any evidence that the efficiency of the vaccines is beginning to dwindle? And as a follow-up to that, there is new, but I think not yet evaluated research that suggests that perhaps 30% of the population over the age of 80 that's vaccinated had no detectable neutralizing antibodies compared to younger people under the age of 65, in which only 2.2% had no detectable neutralizing antibodies. So what does that mean in terms of their protection, not having neutralizing antibodies? And what does that mean in regard to the potential need for annual boosters? So that's a lot.
Okay, thank you. And I think I'm going to ask you questions because you went into immunology, and I think you'll be able to help me. I think that, first of all, there are two ways in which we judge how well or how long the vaccine is going to be effective. And the one is we actually follow up for breakthrough disease, just like any other vaccine, whether we do it for measles or others. And then we decide whether we need extra doses or booster doses. And the other way is to follow up on antibody levels and to determine to what extent. And then when you go into antibody levels, obviously we're looking at the type of antibodies, and then we're looking not only at antibodies, but at the cell-mediated responses, which are more on the memory side. So basically, we're in early days. If we look at the respiratory virus that we're familiar with, which is influenza, then not talking about the variation, in other words, not talking about the mutations and the change in the virus, the same virus, in other words, for the same strain each year, we still recommend a booster dose because it's basically a killed virus vaccine. And the vaccines being used currently for COVID-19, you probably couldn't call them killed virus because they're not killed virus, but they're not active, they're not live virus vaccines, so-called attenuated live virus vaccines. So the live virus vaccines, we tend to see a longer, like measles, mumps, rubella, the long-term immunity. So in that sense, we would say that on the basis of influenza, we have to be very careful to watch both for breakthrough illness and, of course, to look at antibody levels. But the fact that antibody levels decline does not mean that people lose their immunity. So in fact, this decline in antibody levels may not have that much significance for protection. And that's something we still have to follow very carefully. There is, for example, I'll just give it quickly, the hepatitis A virus is an RNA virus, but it's not a respiratory virus, and it's a different mechanism. But it gives you very long, and it's a killed virus vaccine, and it gives you very long-term immunity. So we're really now learning about the COVID-19 one. I would certainly not say right now that we are committed to giving a booster. I think we still need to learn about it, and then to decide whether there's a need for a booster. So, and when to give the booster. The booster may be once a year, once every 2 years, whatever. But that's something I think we still need to learn. So I think that to commit ourselves to any kind of long-term plan, I think would be wrong. The final comment, though, is, but we need to be prepared for that. So in other words, we have to make sure that there will be vaccine if we need it. So this is going to be an interaction between governments and the producers of the vaccine to make sure that if we do need to give boosters, we will have a good supply of the vaccine for booster vaccines.
Thank you. Dr. Morris, much was made about Israel's ability to administer vaccines to the public through its 3 HMOs. With Canada's universal healthcare system, should we assume that that universal healthcare system also benefited the country in administering its vaccine?
No, I think you'd be sorely mistaken, sadly. You know, in Canada, you know, our healthcare systems are rather complicated. And, you know, we have 10 provinces and 3 territories, which are much less populated. And each province has its own healthcare system. So even though we get the vaccine nationally, it gets distributed to the provinces. And then the provinces decide how, using their own systems, and that includes the healthcare systems, but also public health, how they distribute the vaccines. And what it has meant is that each province has tackled it very differently. You know, as I alluded to earlier, you know, over the last while, we've had a tremendous amount of vaccine relative to most countries rolling in. But for the first 4 to 5 months, we weren't getting nearly as much. And the vaccine rollout, you know, was, I would say, quite varied. Right now, as a country, as I mentioned, we're getting between 2 and 2.5 million doses a week. We are able to get it out. We don't have that same grasp of the data, and the fine tuning is not nearly as great in some of the provinces, certainly as Israel's rollout. In fact, in Ontario, where I live, in Toronto, our science table has emphasized the need to model our rollout based on Israel's rollout. We actually had Israeli leadership speak to our science table. I'm a member of the science table for the province to give us guidance, and you know, we've recommended that, but no province has fully followed Israel's model, and because of that, I would say we have been less than perfect. We're doing pretty well now, though, I will say that.
Okay. Dr. Green, there's been a lot of recent talk about Israel's precision medicine for COVID-19, which is said to tackle the immune overreaction that causes many of the symptoms and possibly the long haul symptoms of the disease. The medicine has been hailed as a huge breakthrough by the people who invented it, and Prime Minister Netanyahu recently called it a miracle drug. So what do we know about this drug, and how big of a development could this be? Could it, for example, help India?
Well, I need to make a declaration that I'm not a clinician. I'm a non-clinical physician. I'm an epidemiologist, so I'm going to be going into a field which is not something that I deal with on a daily basis, but I do interact with my colleagues. Essentially, the treatment for COVID amongst the colleagues that I meet with in Israel are still the same treatments that everyone is pretty much aware of, which would be the possibilities of using the antivirals or dexamethasone and vitamin D and so on. The medication that was, I think you're talking about, that was produced by someone at the Ichilov Hospital, the Soraski Center,
Yes.
Is a medication which appears to be, it doesn't cure the disease, but it does seem to reduce the severity. And it's been spoken about really very much as being a phase 1 type of trial, in other words, a very early trial. Since then, we haven't heard too much about it. That doesn't mean that they're not actually going ahead with it. But you know, I would say I would be very happy if something comes of it, but I would be very cautious because we've, unfortunately or fortunately, we've heard these kind of breakthroughs fairly often. Certainly, we hear them during pandemics where people are really working hard to find solutions. So certainly, if there is a possibility of producing a cheap drug, a cheap medication that WHO can be actually, Dr. Nitzan can talk about, as to be able to use for globally, particularly in lower income countries, that would be excellent. And I think that we should all be working on something like that. So that's pretty much what I can say at the moment.
Thank you. Dr. Nitzan, how much has our understanding of the coronavirus changed over the time of the pandemic? And has our new knowledge been instrumental in our fight against it?
That it's quite impressive how fast and what we have learned about the virus, and also what we have learned about us, about humans and the environment. So I think we have learned through those it's like a year and a half, we learned about the virus, many things. First of all, in the first week, and this is very impressive, during the first week, since we heard about it in China on the 31st of December in 2019, by the first week of January, we already had the genetic sequencing of this virus. And that made a huge change, because with this, we had the tests, the PCR, and right away, we used the skeleton of the influenza preparedness globally, with the laboratories, with the sentinels, with everything else. We used that for diagnostics and testing and etc. So that was a big breakthrough already at that moment. And of course, at that moment, the pharmaceutical industry, all the industry for vaccines started to work. They actually started to work many years before, but they used the information they had to upgrade the knowledge they had. So this is a real breakthrough of science during this time. We also learned about the virus capacities, how it goes, how it moves from person to person. We learned that masks are important. We remember those days where WHO said, keep the masks for the healthcare workers and those who are sick. But today we know that when you have masks, you can use them more generally, and they help. We learned about the disease itself, what it does, what it doesn't do, how it can, the clinical picture, the immune system, how it, you know it very well, Professor Premis, but many of us are astonished what it does in young people, older people, and what medicines you can think of when you are imagining the treatment. We are still learning those. We learned that the environment where we live is very important, that one health, the connections, animals, environment, and humans, this interface cannot be left alone. We have to take care of it. We learned that biosecurity is important, as we know before, but here we got, and what we learned is that preparedness, it costs so much less, and it really keeps life and livelihood going. We learned that this is so important. And we have so many more examples of what we learned about the virus, but we still have to learn a lot more. We also learned that we don't know enough.
Thank you. Yes, there's always seems to be more to learn, no question about that. So Dr. Morris, what would you cite as some of the best takeaways that you've seen around the world in the battle against the pandemic?
Well, I think some of it Dr. Nitzan touched on,
Right.
in terms of preparedness. Absolutely. I think apart from that, governance is clearly an important aspect of this. Countries that have struggled with this didn't spend the time in advance understanding how a national response could be and should be governed, and how decisions should be made. So, even what we would consider very advanced countries, the United States, Germany, Switzerland, Canada, often had internal struggles around jurisdictions and who was responsible for guiding the pandemic response. And it resulted in a fairly arduous and fragmented response. So I think moving forward, not only will we need countries to identify how they will govern during future pandemics, but I think it really brought into focus the need for an international consensus around how to approach this. And as I think most people are aware, especially early on, guidance from the WHO by many countries was ignored. So I think moving forward, that's definitely one takeaway. I think the other, amongst the two other major takeaways that I have from this, one is the amazing pace of science and the development of vaccines in particular was really quite astonishing, and has to be one of the most amazing successes of this pandemic. I certainly did not expect that we would have a proven usable vaccine within a year, and it was well within a year. But the other thing, and I'm going to highlight the investigators from the United Kingdom and the recovery trial, who had this platform for evaluating clinical treatment. And they alone, out of the UK, have provided the world with more information about what does and does not work than any other effort internationally. And I think that's definitely a way to move forward with knowledge. And it doesn't only apply to COVID, but it applies to most diseases that affect people around the world. So those would be my main take-homes.
Thank you, Dr. Morris. And Dr. Green, what do you think we've learned from the pandemic and our fight against us that could help us prepare specifically for the next global health threat? Obviously, we didn't prepare well enough, so.
We know that. Dr. Morris and Dr. Nitzan have really covered so much of what should be done, and I'm not sure that I can add too much, but I will make some general comments, and if you don't mind, I'll use a kind of an analogy and quote Dr. Elizabeth Kubler-Ross when she spoke about facing crises. And I somehow think the world generally behaved in that way, and generally does. The first was basically denial. And I think the denial that there was something happening was quite a problem. And then it went to anger. Well, who did it? Well, where did it come from? And why? And then it went on to the bargaining. Maybe it's not so bad, and so on. And then you start getting to the stage where you actually start to come to grips with it and actually recognize the problem and deal with it. And I think that to some extent, we got stuck in some of those stages. And there was a tendency to not believe, and I think that was an early problem, that it's, the whole thing, this is just influenza, it's not so bad. This was the bargaining thing. We don't think it's as bad as they say, and all the rest of it. So this was a major issue, and it delayed actual response in just about every country. And I think that we need to recognize that and to prepare ourselves. I even make a comment, take the epidemiologists more seriously. If there is an issue that is a problem, I think that we are too focused on being afraid of creating panic. I'm not sure that telling people that there might be a major problem and that we should prepare for it is a way of creating a panic. I think what we do is we explain there's a problem, recognize there's a problem, and at the same time explain how we are going to deal with it, even if it's going to be difficult. And I think that the population will recognize that. So I think that this is something we really have to focus on. We were too slow, and I think that we need to speed up that process.
Thank you. Thank you. I think that's a great analogy with Kubler-Ross. We have a question from the audience. Would like the speakers to comment on how vaccination should or change our strategies involving things such as physical distancing, mask wearing, ventilation in indoor spaces in the medium term and the long term. And I just want to tag on to that my own thought that that there will be people wearing masks during influenza epidemic now that wouldn't never have thought of doing that in the past. So anybody want to take this up, this question?
I'll volunteer if you like.
Okay,
You want
go
me to
ahead. You're the
volunteer, or is there somebody else?
epidemiologist. So
I know this is a debatable thing. I think there are a couple of issues. One is that I'm not sure that wearing a mask in a closed space, like in a bus or a train or in a big gathering, is such an imposition on the public. I don't see this as a major imposition. It certainly is if you're wearing it outdoors and all the rest. So I think that we shouldn't believe that wearing masks, as is sometimes quoted as being some of the, I'm sure that there were many other restrictions that were much more problematic than wearing masks. And the last point I'll make, I have somebody, a student of mine in China, and she was telling me what they do there. And I think that China now is giving very good common sense recommendations or regulations probably, where when you go, for example, to get the train, you don't have to wear the masks when you're actually at the station, but when you get on the train, you need to put the mask on and so on. So there are, I think that kind of middle road is useful. I'm not happy with going with the idea that we should just remove masks now and say, well, things are settling down, let's take the masks off. So I'm one of those who's still a mask believer. Maybe the others would comment.
does anybody else have a comment on that? Anybody disagree with Dr. Green?
I think what will inevitably happen is it will be based on overall assessment of risk, right? Clearly, when there's very little virus circulating, the overall benefit of masking is going to be quite small, even though the relative benefit stays the same, right? If it protects you, let's say 30%, it's going to protect you 30% no matter how much virus is circulating. But if you've only got a 1 in 100 chance of being infected because there's not much disease going around, it doesn't really lower it that much, like, but if you've got a 10 in 100% chance, 10 in 100 or a 10% chance of being infected, that 30% reduction is pretty impressive. So I think that the public and governments will probably alter their guidance, and they'll probably time things based on whether it's COVID or another respiratory virus circulating. It will be heavily based on how much disease burden there is.
Thank you.
I would agree with that. Sorry.
Dr. Nitzan?
Yes, I agree with both, but I just would like to add what we see in countries or communities where the masks are taken off now slowly or quickly. We see a marked increase in other respiratory diseases or infections. And that is very interesting. I mean, while we wear masks, many children were, healthier because they didn't have the other viruses that are the RSVs and the parainfluenza and other viruses that are so common. And now that we take it off, we see in communities such a marked increase. And that's interesting. And also, I think we should take it into account, maybe among other risks. Thanks.
So do you think that increase in respiratory viruses among children particularly, but I think we'll see it among adults as well, that it has to do both with mask wearing, but also with congregating? Because if kids have been home and not at school, there's also a lot less contagion. So we're obviously going to see less of it.
That's for sure, but many of the countries that we know in the Western European countries, they really try to minimize the days that the children were out of school. And the young ones mostly continued. The young ones are those that we see now with the and those viruses. And that's, I think we need to think about it. I'm not saying that we have to be covered, but should be in the equation.
Yeah, so I certainly agree with that, which is what I meant with the flu epidemics, you know, that I think even without any recommendations from WHO or the CDC, that you'll see a lot of people wearing masks, especially older adults wearing masks during the flu epidemics. Okay, so another question from our viewers is group consensus on whether or not it's okay to mix vaccines. A shot of AstraZeneca and a second shot of Pfizer, or whatever.
I can start on this. I'm not an immunologist, but I've been involved in tackling the issue of the AstraZeneca safety in particular, and the complications related to the AstraZeneca vaccine, where there's still a fair amount of debate. And what I think we're going to land on is that the main reason why we'll be mixing, it's not going to be an efficacy issue. It may turn out that mixing vaccines, it might actually be more beneficial. We don't have that data yet. What we know is that when you do mix vaccines, the sort of common side effects are in fact more common with it when you mix, rather than sticking to the same second dose as you had with the first one. But we don't know about the efficacy. I think where this is mattering in some places around the world is where they have an opportunity to avoid the adenovirus vaccine, in particular the Oxford AstraZeneca vaccine, in deference for an mRNA vaccine, which is what we're seeing in Canada, and that's being discussed in the UK as well. Many countries won't have this issue to deal with, but those that will, I think most of the time you're going to see they'll opt for the second dose being an mRNA vaccine.
Okay, thank you. Anybody else want to chime in? Yes, Dr. Dorit.
I agree entirely with Dr. Norris. It's not something new for us to mix vaccines. We encounter it with just about all our vaccines. For example, the hepatitis B vaccine, when it was introduced, some people who had received the human-derived hepatitis B in the first dose were then given a recombinant in the second or third. And we didn't see that as a problem. We do it also with the hepatitis, giving the acellular and the cellular. So if it's the same technology, it's almost not like mixing. I mean, it's, if you give, like probably giving the Pfizer and the Moderna doesn't really mean mixing. I think we're talking more about different technologies. And as Dr. Norris said, from the immunogenicity, in other words, producing an immune response, there should be no problem with it. There may be some, what I would think be minor issues in having different side effects. I think that we need to keep watching out for that. But I don't see really any problem, major problem in it. We would have to then determine efficacy, of course, because if you're giving a first dose of a vaccine is known to be poor in its immunogenicity or its efficacy, and your subsequent dose is another vaccine, how many of the subsequent do you give? So then there'll be a kind of balance when how many of the other vaccines should you give? If you're given the first dose using AstraZeneca, should you give 2 more doses of Pfizer or only 1 dose? These are things I think that need to be sorted out.
Okay, well, thank you. If anybody has a quick word for the last question, and then we need to wrap up. Does anybody have news about any updates on the efficacy of the vaccines made in Russia, China, India? Anybody have a quick word about that? Dr. Nitzan, are you aware of what's happening there? But we do need to make it quick.
Yes, very quickly, one of the Chinese vaccines was approved by us for the emergency list, for the WHO emergency list. We are examining very closely the Russian and other Chinese vaccines, as well as many other vaccines that are ready, almost ready to go. Some of them already got our asks, like we asked to do certain things, we need to visit the sites, etc. And looking at the different aspects of first the safety, then the efficacy, and then we are looking also at the way that it's going to be managed globally. They will come. I think that very shortly we'll hear of more vaccines, and then the world will do better.
Well, thank you. Thank you. Dr. Green, Dr. Nitzan, Dr. Morris, thank you so much for sharing your unique perspective, your valuable experience, and thank you so much for the work that you are tirelessly committed to in the service of public health. Such an important area that I think many health systems simply neglect. It just isn't a governmental priority in so many places, and you know, from my perspective at least, it absolutely should be. So I'd also like to thank Dr. Arnie Aberman, who is the president of the Canadian Friends, for his partnership and his support, and the Canadian Friends Executive Director, Hetty Shapiro. So to our listeners, if you have any questions or you would like more information about today's presentation or anything related to the University of Haifa, you can contact us very easily at info@ASUH, American Society University of Haifa, ASUH.org. And we always welcome your donations for COVID-related research, the University of Public Health, or any other university faculty or program. And if you go to our website, info@asuh.org/donate, it will take you directly to a page where you can do that. Thank you, everybody, for joining us today. Be healthy and well, and we look forward to a future connection.